Okay, well, maybe we can go on with the next section. I'm going to be addressing comorbidities, and certainly severe eosinophilic asthma is a disease that we have to face with other where patients may have other comorbidities. As I always teach my fellows, as pulmonologists, we always focus on the lung, but indeed, we really have to have an open mind because, especially when it comes to asthma, where comorbidities not only can coexist, but can actually affect the course of the disease. Let me start with a case, just like Linda mentioned her case. This is Zach. He has a severe eosinophilic asthma, but also comes to us because he has uncontrolled disease. As opposed to the first case, this patient has late onset asthma. His asthma started at the age 26. He's 48 right now. He has been treated with high dose inhaled steroid, long acting beta agonist, and leukotriene modifier. Unfortunately, his asthma continued to be uncontrolled to the extent that he's now is taking oral steroid on a regular basis, and he's using also his short acting beta agonists. He reports exacerbations treated with oral corticosteroid burst, at least 2 in the past year, and continues to have symptoms of dyspnea, night awakening. He's gained weight because of the prednisone, and his ACT score depicts uncontrolled disease, which is 17. Notably, this patient doesn't just have asthma, he has other things. He has nasal symptoms. He has been diagnosed with chronic rhinosinusitis with nasal polyps. He has GERD, and he has obstructive sleep apnea. All three comorbidities are very important that we'll talk about in a minute in maybe affecting the control of the disease. And as you see here, his CBC and differential shows that eosinophil count is 466. He's non-allergic, and his lung function shows airway obstruction. So this is not an uncommon scenario in a pulmonary practice where patients with severe asthma are referred. He's an oral steroid-dependent asthma, so this opens up the doors of even more complicated patients. But also he has other comorbidities. So when we talk about comorbidities of asthma, there are quite a few. This is actually a short list of much longer list. One has to keep in mind that severe asthma is more frequently associated with comorbid diseases compared with less severe asthma. And these could be pulmonary comorbidities, but non-pulmonary comorbidities. When it comes to severe eosinophilic asthma, certainly respiratory comorbidities, especially upper airway comorbidities, are very common, including allergic and rhinitis, including chronic rhinosinusitis with or without nasal polyps. But there are others, respiratory, non-respiratory or respiratory diseases that can cause or be coexistent with asthma. Sleep apnea is a big one. Aspirin exacerbated respiratory disease, which may or may not be associated with nasal polyposis, GERD, and obviously depression, anxiety are only few of these comorbidities. So it's very important when one approaches severe asthma to go through all these by history and make sure you address these comorbidities. When it comes to eosinophilic comorbidities, it's also a wide spectrum. And you don't have to see them all in patients with severe eosinophilic asthma, but often you may see them, or they may be the presentation is going to be asthma, but these patients may have other eosinophilic diseases, particularly EGPA, for example, eosinophilic granulomatosis with polyangiitis, previously called Churg-Strauss syndrome. It can present with severe asthma, eosinophilia, pulmonary infiltrates, and sometimes vasculitic changes. So one has to keep that in mind when you see eosinophilia and asthma. Rhinitis is another eosinophilic comorbidity, certain nasal polyposis, which could be triggered by aspirin exacerbation, but could be triggered by non-allergic mechanisms. ABPA, allergic bronchopulmonary aspergillosis, often presenting with eosinophilic asthma, although usually the IgE level is very high, and many of these patients have bronchiectasis on CT scan and maybe pulmonary infiltrates. Eosinophilic gastroenteritis, very rare, but often a problematic patient, some of these patients, especially if they present with swallowing problem or esophageal problems. And then there are other rarer diseases, eosinophilic pneumonia and eosinophilic COPD certainly is something that now we are starting to look at because for many years we thought COPD is just an neutrophilic disease, but in fact about 20% of patients with COPD may have significant eosinophilia. So let's concentrate on at least a couple of these comorbidities that are very important that this gentleman has or may have. He presents with chronic rhinosinusitis with nasal polyposis. Well, what do we know about this? About 15 to 40% of severe asthma patients reports to have chronic rhinosinusitis with nasal polyps. I always teach my residents and fellows that treating asthma starts with the nose. It's very, very important that the respiratory tract exam starts with the nose. In fact, rhinoscopy is very important. Asking the patient if they have nasal symptoms is very important, but occasionally radiologic testing, CT sinuses and others, and of course, working with our colleagues, the ENT colleagues, is very important if that is a coexisting comorbidities. Why? Because asthmatic patients have a higher severity and frequency of chronic rhinosinusitis with nasal polyp than non-asthmatic individuals. And in fact, having comorbid CRS with nasal polyp and asthma has poor outcomes in both the sinus symptoms, but also in the asthma mortality, but also asthma morbidity and quality of life. So management of patients with CRS with nasal polyp and asthma should include targeting both diseases. Otherwise, the outcomes will not be optimal. And in another subtype of patients where they may present with eosinophilic asthma, often with also chronic rhinosinusitis with nasal polyps, are patients with aspirin-exacerbated respiratory disease. It does not have to be aspirin. It could be non-steroidal agent. The intolerance to aspirin or non-steroidal agents may be subtle. It may not be reported by the patient, but patients who present with the triad of asthma, nasal polyps, and aspirin sensitivity are classic. And most of these patients are non-allergic. Most of these patients present with late onset asthma. They're very hard to treat. Often they are needing oral steroids or even inhaled corticosteroids. And about 10 to 15% of patients with severe asthma may have AERD. So don't underestimate this. So I think that's something that we always ask about. But again, reported history of aspirin sensitivity may not be there and should not be something that you will rule out by just asking that questions. I think the treatment is a big challenge. Often these patients may have polyps, although some of them may not have any polyposis. Now, why is it important? Well, it's important to keep in mind that patients with chronic rhinosinusitis with asthma or AERD, aspirin-exacerbated respiratory disease, are at a higher risk of being on chronic oral steroids than patients with just chronic rhinosinusitis with nasal polyps alone. So it's important to know that having this comorbid asthma on top of this upper respiratory comorbidity increases the likelihood of comorbidity, of poor quality of life, increases the risk of being on oral corticosteroids. So I'm going to stop here and I'm going to maybe ask Linda in one of the questions that always comes to mind, and it'll be interesting to know what you do in your practice, Linda, with patients with upper airway disease and asthma. Do you tend to manage them yourself? Do you have a multidisciplinary approach with your ENT colleagues or allergy colleagues? What do you usually do when you face these patients?
Yeah, I think in an ideal world, we're very fortunate here that we really do have a great interdisciplinary team for managing these patients. We work very closely with our ENT rhinology subspecialists who are really experts in managing the surgical management of polyp disease and are very enthusiastic about medical management for their patients, particularly after they fail their first polyp surgery. We also work very closely with allergists and laryngologists to deal with other comorbidities related to these patients. But this is really one of the most challenging ones, and one of the areas where there's just been a lot of movement in this field with the FDA approval of biologics for their concomitant sinonasal disease as well as for their asthma. So we like to really take that approach. And if you are out in the community, management of some of these patients can be some complex. And so this may be a group of patients where it's good to refer them to a specialty program for multidisciplinary care.
So, Linda, how often do you order CT scans of the sinuses in such patients? What's your threshold?
It's funny that you asked that. It's evolved a little bit. I think, I think in patients with high steroid dependency, I often will do that to look for polypoid disease. But I think, really CT becomes most useful when, when surgery is being contemplated. So I've really taken more of an approach of referring them for endoscopic evaluation and really deferring CT depending on what their endoscopic evaluation is, and just working on determination of indication of CT for the colleagues. But I think if I do have a patient with severe anosmia and really severe symptoms, I will often order this before I send them off to my rhinology colleague. So it's really decided on a case-by-case basis.
Mm-hmm. Yeah, I mean, I'm more, I have a lower threshold of asking for imaging, although I sometimes fail because the insurance, just like this morning, I had to do a peer-to-peer because, insurance company wanted to know why I'm requesting a CT sinus when I'm a pulmonologist. So I have to remind them I'm an asthma specialist and I treat the airway from up here to down here.
Down there.
And I've found surprises because even though I do quick rhinoscopy, I'm not an ENT doc. I don't do laryngoscopy or go in the sinuses. And sometimes I miss diagnosis of nasal polyps. Often these patients obviously have nasal obstruction, and I just treat them like I treat with allergic rhinitis with nasal steroids and leukotriene modifier. This patient is on all these and saline irrigation, but I think I'm as like you are. I have a much lower threshold if patient has failed surgery or told me had nasal surgery in the past and coming now with uncontrolled asthma, eosinophilia, and nasal symptoms. I have a very low threshold of imaging and referring again to ENT. And actually, we've been working very well with ENT docs on these patients who failed surgery because they are very high risk of being controlled on oral steroids. And now we have other options that we can offer them, which is really unique and important.
Yeah.
Well,
I agree. It's very exciting. I mean, the response to some of these patients who, historically have been very difficult to treat, without having to resort to significant oral corticosteroid burden, has been a very exciting time for those of us who have been around for a while.
Yes, I agree with you. Well, I think, Linda, you're going to be talking about oral steroids, just as we mentioned it, and chronic use of oral steroid in this difficult to treat asthma group. Maybe you can walk us through your case and we'll have another discussion point right after.